I'm Dinatri. Hi, I'm Dinatri, and I'm here to talk about my AMC Part 1 journey and how to prepare effectively and what our EdCare program has for you. So, first of all, I want to start everyone by thanking for joining us today in our Zoom meeting. It'll be a quick session of what AMC is and what we have for you, and a little followed by a little question discussion. I would like to introduce myself. I recently graduated from medical college. I graduated last year, and I did my clinical internship, and I have cleared my AMC exam in this year, March. So that's pretty much it about me. So I'm sure every one of you who have joined already knows about the AMC MCQ exam, but I would like to give a little brief explanation about the exam itself. And I will also talk about my plan, how things worked for me, how I worked for the exam. And last, I would like to speak what our program has planned for you. So we'll go ahead with that. So I'm sure this information all of you all must be knowing already, but the MCQ exam has 150 questions, and you have 3.5 hours to finish that. So if you do the math, you will figure out there's about 1 minute and 20 seconds per question. But I would like to say, don't think you have more than 1 minute for a question. Always think that you have to finish a question within 1 minute. That's mainly because in AMC, you find different types of questions. There are some questions with a short stem, just a single stem, and there are also questions with about 4 5 liners, even 6 liners. So if you think each question has 1 minute and 20 seconds in your brain, that way you will take time more than too much time for short questions and not have enough time for long questions. So I would say just think you have 1 minute per question while you're doing or while you're practicing. And yes, this is a computer-based exam. You don't have any physical exam in AMCQ. So, so I would like to talk about my preparation. So I took about, sorry. So I took about, just give me a minute. I'm just trying to, okay, all good. So once again, I would like to say that this is what worked for me. And I believe that it might be different from individual to individual, depending on the time you're planning to spare for your studies per day. I understand all of us have different commitments, different work routines, and all of that. So, this is what worked for me. I did my preparations while doing my internship. So, if it might differ for you, I'm first going to share how I worked and how my timeline went and how my study structure went, so you all can get an idea of it. So I took about good 3 to 4 months for theory, and then after covering most of the sections that I could in theory, I went for good 2 to 3 months of questions. What I followed was a structured weekly plan by sections. And by sections, I mean specialities. So what I did was I separated each week for a specialty. I would start with respiratory, cardiology, neurology, and give each specialty a week. And my goal was to finish one specialty each week, no matter what came up. I will explain this a little in detail in the next slide, how I planned my week. But this was my basic go-to theory studying structure. And after finishing all the specialities as much as I could, then only I went to questions. That is because I had time and I was taking my time to prepare for this. So you decide on your planning timeline and then decide how you're going to work on it. So this is how my weekly study structure went. I took about 2 to 3 days to do the theory part, and I used the book John Murtaj, the 8th edition. In my upcoming slides, I will explain more about my theory, studying, and the textbook and all of that. For now, I'm just going a brief structure of how I used my week. So I took about good 2 to 3 days to study theory. And then what I would do is I made my little short notes. Let's say I'm in my respiratory week. So what I would do is go to John Murtag's book. I mean, there are hard, I mean, you can buy the hard copy. I used a soft copy. I used my iPad and made notes. So I would highlight the important topics like asthma, pneumonia, COPD, and all of that. And I would just write down the important things on my own personal short note. That way, I knew what are the most important things. I knew what the treatment would look like, the diagnosis, and all of that. And I would make my own note. And I would maximum give 3 days for theory out of my week. And for the rest of the days, I would continuously practice MCQs because I don't know how to emphasize this enough. Questions are the most important thing in preparing for AMC because no matter how much you sit down and study theory, I don't think any of us can like ace completely memorize everything in the textbooks or the guidelines or whatsoever, and you can't be making notes out of like respiratory, like all these medicine topics, surgery, gynecology topics are vast topics, so you can't be making notes. It'll take you books and books. So what I would do is make a very short note and get into questions, and I would update my notes while doing questions. So as you can see, I use the AMC handbook. I know it's a bit of a controversial topic there because everybody says the handbook is quite old. It's from 2005, it's been 20 years. But I would also like to say, if you think of it, that's the only MCQ resource AMC itself has given us. So I know it's quite old. The answers might be different now, but I say it's best to stick into that book just when you finish studying theory. Do the relevant questions in the AMC handbook that was given by the AMC itself. So I think that's the best for me. I worked with the handbook first. Then I would go to Amadex, do the section wise questions. I would finish, if I studied respiratory this week, I would finish all the respiratory AMC handbook questions, then finish the Amadex respiratory section. Then I would go to MPLASX, and then I was actively involved in some group discussions. I made a couple of study partners that they were also planning to take the exam in the same time as me, and it really helped me. It was really helpful because we were all in the same mentality, we were all in the same enthusiasm. So whatever the hard questions or whatever the controversial questions we came up whilst preparing for our week, we would share it on the group chat, or we would have Zoom sessions and continuously discuss. And everybody could bring up their own notes and their own guidelines and their insights on that question. And that's how we settled to an answer. So I would say group discussions played a main role in my preparation. And with all of that, after doing questions, after doing group discussions, I would definitely update my note. The note I made in the beginning of the week would be a very completed, very useful. It would be like full of like a knowledge resource at the end of the week, and I would go to the next specialty next week. That's how my weekly study structure went. So I would, just like I said earlier, the power of practicing questions. I don't know how to emphasize this enough because that is the go-to way to ace this MCQ exam. This is not a theory. I mean, it is theory, but you can't be studying all the theory for this exam. You should know this is a very tricky exam, so you should know how to tackle it. And in AMC, you won't be getting all the diseases, random diseases won't be popping up. If you properly do questions, you'll realize there's quite of a repetitive. I'm not saying it's repetitive, the question per se, but there's a repetition in the diseases, the type of questions, the structure. There is a repetition. So if you have, even if you haven't covered all the theory, but if you have done so many MCQs and practiced them, you would at least know what to know for the exam. So that's why I'm saying practicing a lot of MCQs will help you a lot. And then learning from your mistakes. I mean, let's say if you have thought you're going to do 50 questions for a day, you wouldn't want to get 50 out of 50 that day. I mean, the more you do mistakes, it's the best for you, because let's say you do a mistake, you would definitely go and search it up on the guidelines, on your notes, on John Murtaj, and then you will definitely remember it more than a question you got it right. So I would say it's the best way to do questions and learn from your mistakes and find what went wrong. Find why the other answers are not the answer and this is the answer. Just without sticking, okay, for this question, this is the answer. You can't be memorizing like that, because AMC has this tricky way of like flipping over the answers and all that, and asking the same question again. So you have to find your reasoning on why you're securing this answer in your question. So that is there. And like I mentioned before, group discussions, they amplify learning, because let's say you're having a day where you can't give your 100% to your studies today. But let's say somebody else in the group is in their power mode, giving their 100%, or have had opened all the guidelines on their tabs, and then they are fully committed for it. They might help you with a question that you're finding difficult to find the answer today, right? So group discussions are very important, and others might find guidelines and notes that you would never find by yourself. So stick to a group that is really committed just like you, and that will really help you. And that's what we are trying to give you. That's what we are trying to make here. We are going to make a little space, like a little group for you, where you we can actively discuss, actively share our guidelines. Even if you have a question along your preparation, you can share it on the group. We are going to have continuous Zoom sessions weekly, in that you can ask from others. I'm sure somebody else will have a better insight on that. So group discussions amplify learning. That is a very important thing in AMC. And also, as much as group discussions are important, you wouldn't want to believe everything that's said or shared on Zoom, or whatever that's said on WhatsApp or anything. You wouldn't want to believe that. So always verify your answers with guidelines, because in AMC, you do not have like a proper syllabus or something to follow exactly. What you have is a continuously changing set of guidelines. That's why people say that AMC is very tricky, and that's why most of the people say AMC is very hard to pass, and it's the hardest exam and all of that. That's because it doesn't have a proper syllabus to follow. It has guidelines to follow. So, as you and I all know, guidelines are something that keeps on changing. They change with research, they change with years, and they change with the whoever the head is in charge of it. So you have to continuously be in track with guidelines. What you have to, so along my presentation, I will explain to you, and we also have Dr. Shahani, who is planning to do lectures with us. So she will also show you after this orientation program. She's planning to discuss a few high yield questions. So those answers are based on guidelines. She will share the links with you for those guidelines. So she will cover that too. So that always verify your answers with guidelines. That's the best advice I can give you regarding AMCQ theory part. And yeah, so like I said, you can do a lot of questions in active group discussions. So these are basically my resources, what I used. For books, I use the John Murtaj 8th edition. You can find it online. I think you can download it. And then I also use the AMC MCQ handbook, which is pretty old, but I use the concepts of it. And then I used 100 Ks of ethics. That's a USMLE book, but I followed it for the ethics part. And then in AMC, you have screening. I will be talking these specialities in the upcoming slides. I just want to say the resources I used for now. So I used the Red Book. There's a book called Red Book for screening and population health part. And the Q banks I used for Amadex and M plus X. So you can find so many Q banks online. There are so many new ones up there, but I kind of believe these two are the old ones, pretty straightforward. So yeah, so these are the books that I mentioned. This is the John Murtaj 8th edition book, and this is the USMLE medical ethics book, and this is the MCQ handbook that we all know of, that was given by AMC itself, which is pretty old, but we still stick to it because that's a book they have given us. And this is the red book I mentioned earlier. It has all the guidelines for preventive medicine, the screening, and all of that. So it's pretty useful. Also, I think the latest is the 10th edition. We are currently following the 10th edition. It's always better to check if there's any up new edition. So these are the books that I used. So about guidelines. Now, guidelines is a very, very important thing when preparing for AMC MCQs. So I would like to brief my guideline use in these four areas mainly, I guess in three areas. I used RACGP guidelines and therapeutic guidelines mainly for medicine and surgery. So if there's anything that came up, like a medicine related question, I would type the topic and type RACGP guidelines, and it would come up. I will explain how I did it. I mean, I think I have a picture next. I will explain it there. And then for pediatrics, I would go for RCH guidelines. And then for obstetrics and gynecology, I would follow RANSCOG. It's Royal Australia New Zealand College of Obstetricians and Gynecology. This is RCH is Royal Children's Hospital, and RACGP is Royal Australian College of General Practitioners. These three were my go-to guidelines. These three were my best friends during my preparation. Whatever the question that came up, I would just go up on the internet and type the question I had, and I would type RSAGP at the end. And then it would come up and I would read and read articles. So that's why I said the group discussions are very important, because sometimes before you do your own reading, somebody else might have done it and just share the link already for you. So that would make things easier for you. That's a big pro of having a active group discussion. And yeah, this is about the guidelines. And then for others, there were also other guidelines, but these three were the main ones that I followed. There were South of Australia, Queensland guidelines, different hospitals. Likewise, I found so many other guidelines, but these were the main reliable ones. And then there's this guideline type called therapeutic guidelines, which is mainly followed by the practitioners in Australia. It has multiple sections. It doesn't just stick into medicine or surgery or anything. I think it has almost all the sections. So that was also really helpful during my preparation. So yes, this is a screenshot of how I would search on guidelines. So let's say I was studying for asthma and I wasn't pretty sure about treatment, and this is in pediatrics. So what I would do is, as you can see, I would type asthma treatment and RCH, and this would come up. This is Royal Children's Hospital, and I would go to that, and it would have all the explanation, the charts, the guidelines, and everything, the latest things that Australian practitioners basically follow. So I would like to talk about building strong notes. Um, so you have to update your notes daily. You can't be making your notes on the first few days of the week. If you are following this weekly structure, you can't be making it and arguing that your note is right no matter what. You should be ready to change it. Just chop and crop and add your own things while studying. So you have to continuously update your notes, because AMC, especially these Australian guidelines, they keep studying. I mean, I would like to say you as an example. So when I started studying last year, um, the beginning of the year, certain things were different, certain treatments, the first line medications were different. When my exam got closer, I had to cut my own notes and change things just because the guidelines changed. So I think you all have to be on the go with the updates that are coming. So you be ready to change your notes continuously, and you have to be very short and you have to summarize everything. You can't be making like pages and pages for a small short topic. So you have to make it as short as possible. And you have to, yeah, like I mentioned, you have to add short reminders that this is from this guideline, this is from there. So when you come back to your note after months, you know where you got this from. So if you want to read more about it, you can go back to the link, and likewise. And I would recommend at the end of each week, like I said before, we are going to separate weekly, like specialty weeks. At the end of each week, just test yourself and see. Just put yourself on a little timer. Take 20 questions from Amadex or MC, I mean, the handbook or anywhere. Just pick some questions and do a little test and see if you have, like, have a basic idea or of what you have done throughout the week. Just it's always good to test yourself and see. So doesn't have to get 100 out of 100 for anything. Just a test would help you get an idea of where you stand. So I would recommend that. I did that, so it worked for me. And so this is few pictures of my notes that I made just for y'all to get an idea on how I did my study preparation. These were basically made in the first few days of my week. These are from screening and some of them are from I think psychiatry and all of that. So as you can see, I have been continuously adding while preparing, while doing questions, while following guidelines, continuously adding and writing things here and there. So that's for y'all to get a basic idea. So these are some of the lessons I learned from my preparation. So some of y'all can make use of it. I really believe consistency beats intensity. So that is because you don't have to like study one day for 20 hours per day and then go deep into a research about the topic or anything. I think what you have to do is be consistent with what you're doing. So if you study a day very intensively and not touch a book for about another 3, 4, 5 days, and then you get back to work or questions again, that's definitely not going to help you. So I would recommend separate some time from each day for your MCQ preparation. It doesn't have to be long hours, even if it's just 2 hours, or even if it's just 1 hour of your day in the beginning of your preparation. If you're doing that right, I feel like that will be the best thing you can do to yourself during this preparation. And I told this before, I'm telling this again, discussions over memorization. I mean, when you discuss with somebody, it just goes into your brain. It just you just remember the things you talked, you remember the things where you went wrong and all of that. So give priority to discussion. Find a good set of study mates that who will be equally committed as you. That is also very important because you can't be dragging others. You're already dragging yourself for the exam. So find a set of study mates that will give a good energy, good study energy, and continue discussions. And guidelines are gold. Like I said before, this is a guideline based exam. It continuously keeps changing, so you have to prioritize on guidelines and all of that first, and build your own notes. Don't try to read others' notes. So, like I shared some clips from my own notes. I mean, I really wouldn't be able to understand from other people's notes because only I know what I wrote where and which guideline I got it from. And some of these things I've written here and there in red, those are things I learned while doing questions. Like it was really important for me when I was very close to my exam date, when I was going through them while doing questions. So I found it really easy to find things out. So build your own notes. That'll be really helpful for you. And also, this is basics. Believe in progress, not perfection. Like I mentioned before, in the beginning of preparations, you shouldn't be getting everything 100% correct, or you shouldn't be knowing every guideline by heart. You should be doing mistakes. You should be learning from your mistakes. And that is how you progress until your exam date. So, those are pretty much the summary of things that I learned during my preparations. And um, I would like to now talk about how we will work in this course, in this EdCare 4 months crash course. This is what we have planned. So we kind of have like, we also thought we'll use this weekly structure in our course. So we have decided to use a weekday. So far it's going to be Wednesday, or next class might be on Tuesday. We will confirm it on the group. So most probably it'll be on Tuesday. So we will separate a weekday for the theory class. In the theory class, I would like to say we are not going to be teaching word to word. This is going to be a guidance for you all. So what we will do is, since we have taken the exam, we know what are the high yield topics that you will find in questions. So if we start with neurology, for an example, I'm saying, we would say these topics are important. Read this at home. Go through these pages in John Wotage. Read this and these guidelines. We will share the links and all sorts. So likewise, on a weekday, we would give you what to do with your theory. And then until Saturday, which is going to be our question discussion class, you have time to sit down and read those things we told you all to read. Make your own notes, do questions as much as possible. And if you have any doubts, bring it up to the next class, which is the Saturday class, the question class. Bring it up there. We will discuss. We will all get together and find answers. So, this is what we have planned. We are going to be your study partners. We are going to be your study help, support. So, we'll get through this in these weekly plan structures together. So, what we are going to do is theory, MCQs, focusing on guidelines. We'll mainly focus on guidelines. Whatever the questions will come up, we'll get together and search it up on guidelines and figure the answers together. And we are going to offer you all an interactive discussion of a group chat. So we already have a main group chat going on. So we are planning to make another group chat with the people who are planning to join our course, and all of y'all who have already joined the course today, the meeting today. We are planning to make a group chat and have very active discussions there. So I want you all also to participate in that group chat and bring up your questions, bring up your answers, share your links and all that. And I think that is the only way we can, I mean, you can get through this exam. You have to be very interactive in order to find your answers. And we would give encouragement and support, like I said, and guidance on what to do and what not to do. And that's what I said, like, when you're preparing for your theory, you can't be just studying everything that you see on guidelines and John Mutaj or whatever the textbook that you're going to follow. You need a guidance. I had that. I mean, most of the people who did the exams, I'm sure they at least asked from somebody who did the exam before. That way you know what to study and what to not waste your time on. So we are planning to give that support to you in our AMC crash course. So those are pretty much the things how we'll work this through. And these are the sections that I mentioned earlier. These are the sections that we are planning to cover throughout our course. These are like the main specialities you'll find in AMC MCQ. As you can see, some of these ones can take 1 week. Like I said, we can do the weekly structure like respiratory, renal, neurology, and all sorts. And you can see there are pretty big topics like cardiology, general surgery, and then obstetrics and gynecology. Obviously, you can't pack everything of that into 1 week. So we might need a week or two for those vast sections. But these are the things that we are going to follow in our AMC course. And also, I would like to mention that there are some topics like ethics, screening, and statistics and population health, which are pretty much not um, some things that we are not very familiar with, very Australian guideline focus. So we shouldn't be avoiding those sections just because they are. Just because we think they are not as important as the other main topics, these little topics are as important as them, because you have to probably have a pass rate of all these sections in order to completely pass your exam. So we will guide you through, we will find answers, we will check guidelines, we will follow the textbooks that we can and all of that through our course. And so this is basically our plan. So today we will be having this little orientation program, orientation presentation, followed by the questions. Like I mentioned earlier, we have Dr. Shahani, who is waiting to discuss you all through a few questions from selected high yield AMC topics. She's going to find the answers for those questions are based on guidelines, like I mentioned before. So she'll be sharing those guidelines with you all, so you all can get an idea how we are going to tackle each question, how we are going to find answers for each question. And then our next class would be Wednesday or Tuesday. I will confirm that and update it on the group. And that would be our first theory class. And then followed by the Saturday class, which is going to be the question class of the theory class. So we give you a couple of days from that Wednesday class to Saturday class to arm up and, like, fully prepare for the question class and come. So when we share the question on the screen, you can directly share your answer on the chat, or if you have any questions related to that theory, you can bring it up and share it on the chat so that others can see, so we can discuss it together. Let's make it a very interactive group discussion, because I feel like if it's going to be me and Dr. Shahani who are going to give you all the lecturing and the classes and the discussion. So if it's just us talking from this end, I think it's not going to be pretty helpful for y'all. I feel like y'all should be as interactive as we are, asking questions. Just unmute your mic or raise your hand. There's a feature like that in Zoom. You can just, be very interactive during our discussions. And yes, so I would like to say the first three classes would be a free trial for anybody who likes to see how this program is going to go, because you can always come and see if it's going to work for you, if it's going to work with your plan. So first three classes would be free. So it'll be this orientation program followed by the questions. And the first theory class and the first question class would be free for you all to join, share with your friends, share with anybody who's planning to take AMC. I mean, it doesn't have to be that you have booked the exam already. Even if you want to take AMC, I mean, you would be still in medical college. It's okay. Just for y'all to get an idea how to prepare for it or anything, you can just bring up your friends and all that. So you can join the free three trial classes and see how it's going. So this course would be for 4 months. Starting from now on, we are planning to finish it within 4 months. And we will provide you all with a timetable soon. That's with the specialities divided weekly. So you all can have an idea of what we are going to do, when and what. So we will provide you all a timetable very soon. That's going to be our plan. And I would like to say thank you for joining us today and listening to this. And I feel like every one of you is capable. And I mean, everybody who has joined here already are either medical students or medical just fresh graduates or already practicing doctors. I'm sure with pretty much like a lot of experience, it could be. But I feel like all of us have the knowledge already. It's not that we don't know medicine, it's not that we don't know surgery or whatsoever. It's just that we need to follow this specific structure for AMC. The structure is the most important thing, to follow the guidelines, and like this structure belongs to guidelines, active discussions, and doing a lot of MCQs. That is how I can summarize the preparation structure for this exam. So I wish all of you all good luck in preparation. And if you all have any questions regarding anything that I said so far, or anything that you all have been having, feel free to ask on the group chat, I mean, on the Zoom chat. And if there's anything I can answer, I will answer. So that's pretty much it about my preparation and what we are planning to offer you all through this course. So we have Dr. Shahani next in line, ready to guide you all through a few selected questions from high yield topics. Dr. Shahani, are you
Hi,
with us? Hi, Dr. Shahani.
hi,
So,
Dimitri.
yeah.
Thank you for that really, really expansive introduction. I hope it
Thank you.
helped everybody.
Yeah.
And so from now, I'll just take you through with
Mm-hmm.
how the classes will be done,
Yes.
so that you get an idea of how we'll be working through the theory classes as well as the question based classes. So,
Yeah.
like Dr. Dineti said, on Wednesdays, we'll try to do theory and give you some time to go through that theory and any additional stuff around those topics so that you can be ready to do questions with us on Saturdays. so that this session will be sort of interactive than us just giving your lecture and you're just sitting there and listening, then nothing's gonna sort of stay in, right? So let me just share um just share the screen. So today, what I'll be doing basically is I'm not going to stick to one topic. Uh, I'll be doing questions from several areas just to give you all an idea of uh, the scope of this whole exam, as well as to give you all an idea of uh, how you're supposed to look into guidelines and how these questions are actually related to the guidelines. So it's not that they ask questions for where you cannot actually find the answers or you have to assume answers. These answers are there in their guidelines. So those guidelines that Dr. Dinetti mentioned, those are the main ones that we follow. And then certain things, I think, especially in obs and gynae, their Ranscock guidelines are not that vast. They tend to go by the Royal College guidelines as well, that is the UK guidelines. So then what we do is you're supposed to read through the NSW guidelines. So if you cannot find something in obs and gynae on Ranscock, you need to go through the NSW guidelines. Same with pediatrics, but pediatrics, most of it is there on the Royal College, Royal Children's Hospital guidelines. So if there's anything that cannot be taken from that, we will let you know, and we will also share the links, right? So just to for an introduction, so I'll be mixing a few topics and doing. So in between, if you guys have any questions or y'all need to clarify anything, please do ask. And another thing, I'm not sure, Dr. Dinesh, did you explain about the number of questions and that there are 30 unmarked questions?
I explained about the number of questions, but I couldn't mention the unmarked questions
So
situation. Maybe
what you need to
yeah.
know is, like, out of the 150 questions, there are 30 new questions that are coming up by AMC. Like, they've created some new questions that haven't been tested before, and those 30 new questions are unmarked. So they don't give you a score for answering those questions because it's more like a pilot study. So they have 30 pilot study questions, and you wouldn't know which is the pilot study question and which is the actual marked question. So you'll be answering everything in the same pace. But one thing to know is, in those last 20 questions out of that 150, the last 20 questions will not have any pilot study questions. So the last 20 questions are definitely marked and scored. So that's why we say you need to try and finish these questions as fast as possible, like marking your time as 1 minute or less per question, to make sure that you are able to get to the final question as well. Because most of the time what happens is you're unable to answer the last few questions. You run out of time. Even if you practice at home, once you go there, with the stress and everything, you tend to sit there and read the questions and stuff. You might lose track of time. So always watch the clock. There's a clock on the right hand side of the screen. It's constantly counting down, so you can see your time. And make sure that you have answered those last 20 questions, because that is definitely scored. And from question number 1 to 130, there'll be 30 questions spread out that are not marked, right? So basically, we are being marked for only 120 questions out of the 150. So let's just start with this. I'm going with the pediatric question first. So this is one of the past questions. Is 4-month-old Paul is diagnosed with pertussis. The father is an engineer and mother is a housewife. They both have completed the childhood vaccination against pertussis. Paul has a 5-year-old sister. Which one of the following is the most appropriate management plan to consider for Paul's parents regarding pertussis? So here they're asking about Paul's parents. So they're not even asking about the treatment of pertussis for the 4-month-old. Uh, so around pertussis, there are a lot of points that have been questioned in the AMC. So when you get a question like this, what you need to first do is, okay, go to the Royal Children Hospital guidelines and read pertussis. When you read pertussis, you will actually be able to answer majority of the questions that come under pertussis in the past papers or the past questions, right? So what AMC does is, even like in your month, if you get a new question that has never been asked before, what you need to do on that day is go quickly to the guidance. Don't only answer that particular question, because what I notice what AMC does is, when they put a new question in, uh, they actually put about 4 or 5 questions on that same topic, and all the answers will be in that particular guideline. So what you need to do is, when you find out, okay, there's a new question that has been dropped in by AMC, you find that topic and read the entire guideline, so that when you are doing your exam, the rotating question might be something different based on the same disease. So you're able to still answer it. So here, what I'll do is I'll show you how we go through with the, before we get to an answer. So they are given a few answers here. Immediate booster immunization. This is for Paul's parents, right? And then a 10-day course of erythromycin, that is prophylaxis. Or do we go for a course of the immunization, the vaccination, or a swab, or pertussis immunoglobulin, right? So here we have, I've just given you the link to the RCH guideline for pertussis, right? Uh, all these notes are taken straight from the guidelines. So when you go to the RCH guideline, they have these tables. Those have most of the important information. Rather than, if you're in a hurry, especially, rather than reading the symptoms and signs and all of that inside, what we really need to know mostly is the management, right? So most of the questions around AMC is more than asking you what's the diagnosis, they ask for the management, right? So these tables are really important. Now, if you take this table, for example, around this table itself, there must be about 5 or 6 previous questions, right? So here they're telling us how we go with the prophylaxis for pertussis. So when do you give prophylaxis? That is obviously when someone is exposed to a diagnosed case, right? So you can go for antibiotic prophylaxis. Let me get the laser pointer here. So first one is antibiotic prophylaxis, right? So you decide on that by checking how they were exposed to the index case. So did the index case have less than 21 days of cough? Or if they say that the index case was on antibiotics, you must check how many days of antibiotics. So when you get the question, now here it's not mentioned, but there'll be questions where it's necessary, and they would mention, say Paul has been started on antibiotics, but then you need to see, was it less than 5 days of antibiotics, or Paul has been having this whooping cough, right? Uh, Less than 21 days of cough. So generally, the cough is something that starts early, right? So that's why they take 21 days of cough. Or if your first contact was within 14 days, right? So these are like the points that you have to see. Was it within 14 days of the person being infected? Or was the cough less than 21 days and antibiotics less than 5 days? Then you need to consider, okay, prophylaxis, right? And here on this table, they mention who needs the prophylaxis. So sometimes they will give you a case where actually they don't need prophylaxis. And the answer on the table is prophylaxis is not needed. So how do you decide whether this person needs or doesn't need? So all children uh, less than 6 months or who haven't completed their routine pertussis vaccination need prophylaxis, antibiotic prophylaxis on exposure, this kind of contact, right? Or if that child or even adult has someone in the house who is less than 6 months, or they are coming into contact with another child in the nursery or in their childcare who is less than 6 months. So if the baby is less than 6 months and if they are older than 6 months but they have a contact who is less than 6 months, that child needs antibiotics. So there have been questions where they talk about a child who is 7 years of age but has a little brother or a sister who is a few months old, and then they ask, does this child need prophylaxis? Yes, they need prophylaxis, right? So we'll go through all those questions. What I will do is on the Wednesday class, we will go through the theory like this, and all those remaining questions will be going through on the Saturday class, right? And then when do adults need prophylaxis? So irrespective of their immunization status, right? So one is especially those in the last trimester of their pregnancy. In Australia, last trimester of pregnancy, uh, it is recommended for them to take the uh, pertussis vaccination, right? So that's DTPA. In the last trimester, they are supposed to take it. So regardless of the immunization status, though, if they're exposed, they have to go for prophylaxis. Healthcare worker in a maternity or newborn hospital, and childcare worker coming in contact with infants less than 6 months, and household member less than 6 months. So if it's the parents and if they have a baby who's less than 6 months, the parents need prophylaxis, right? So let's see the other one. So the and then this has also been a question. How you manage a child, right? Who has pertussis? Do you send them to school? How long should they be away from school? Those kind of questions, right? So exclude from school and presence of others outside the home, right? Until they have received 5 days of therapy and coughing is more than 21 days, right? So that whole whooping cough, if it's more than 21 days, then they're considered not infective if they haven't received antibiotics. But if they have received antibiotics, after 5 days, they can go back to school, right? So I would advise you when you're doing pediatrics to make a table uh, with the number of days they have to stay away from school or away from work or whatever for every disease. So that is a very common question in AMC. They give certain diseases, especially in pediatrics mostly, and ask you how many days should they be kept away from school, right? So you can make a table there. As we go, we can add it to the table and we give it to you, right? So vaccination, unimmunized or partially immunized children diagnosed with pertussis should still complete the schedule, right? So even if they have got the disease, they need to complete their schedule. Then uh, close contacts that are not up to date with the pertussis immunization need to be given one of these two vaccines as soon as possible after exposure, right? So what do you mean by up to date? So one thing in adults is even though you had the childhood vaccination, after about 10 years, it's considered not effective. right? So over there in Australia, they recommend having the DTPA vaccination every 10 years for adults, right? And so like here they say DTPA for adults who have not had pertussis vaccine. Then another thing in the MCQ they ask is they put both of these vaccines and ask which one, right? So you need to know that over there they have a version for children and a version for adults. So this capital DTPA is for children. The simple DTPA is for adults. That's because the children's version has a kind of a higher dose, and for adults it's a milder dose because it's just a booster, right? So you need to remember that also because it comes frequently. Uh, yeah, so school exclusion, unimmunized less than 3 doses, and close childcare contacts less than 7 years of age must be excluded from school. So that is uh, anyone else, right? If they are not immunized, uh, and the contacts who are less than 7 years of age must be kept away from school because even though they haven't got pertussis, they can carry the disease to the children in school, right? And if you're sure of the number of days of the last exposure, there's 14 days from the last exposure or 5 days of antibiotics. So this is for the contacts. So here in pertussis, there's a lot of math sort of to remember, but it's absolutely necessary so that you get your answers right. So how do you see a diet? So we'll go through this properly when we are doing pediatrics. Is just to give you an idea. How do you see a diagnosed case? How do you decide on school exclusion? Who gets vaccinations? And then how do you decide when whether a case is infectious or not? What is the duration and what is the duration of cough, right? So these things we will go through in proper detail and explain to you when we're doing the pediatric class. So from whatever we know, uh, what do you think the answer here is? Is there like uh, anyone who wants to give it a go? Okay, so we just go on with it. So like we said in the guidelines, they need an immediate booster immunization against pertussis because it's been more than 10 years since they received their vaccine. They only have a childhood vaccination, right? So they need to have their pertussis vaccination, right? So just to see another question, so this is how a cardiology question, I'll just take it to the questions and our theory as well. So 65-year-old man presents to the emergency department with a complaint of chest pain radiating to his jaw for the past 2 hours, and he's given aspirin, nitroglycerin, and supplemental oxygen. So with these measures, the chest pain subsides, and ECG is obtained and is as follows. I'll show you, and the troponin level is requested with the result still pending. So we will go through a bit of ECGs as well. Uh, so here, what can you see? How anyone? So we can see like ST elevations here in lead one. So when you're looking at an ECG, always we'll talk about the squares and the heart rate, but that's actually not that necessary for AMC. Just be able to diagnose certain common conditions, right? So when you're looking at an ECG, when you're excluding an MI, first look at lead 1 and AVL together, because those are your anterior leads, right? And then next you look at lead 2, 3 and AVF together. These are your inferior leads, right? And lead 2 is the one that gives you the constant, right? So lead 1 and AVL together, lead 2, 3 and AVF together. So here, when we look at lead 1 and AVL, we can see ST elevations. 2, 3 AVF is the other way, right? So, and then we have some in the lateral leads as well. These are ST elevations. So this is basically an ST elevation MI, which is anterolateral, right? So now here, like you see, AMC is not asking you for the diagnosis, but they are expecting that you have come to the correct diagnosis. And based on that diagnosis you made, they want your management basically, right? So if you send the patient home, obviously that's not going to happen. We have already diagnosed a STEMI in this patient. So what is your next management plan? So since the patient has presented early, he has come within 2 hours, so then we can go for PCI, right? Thrombolysis also you can consider as an answer if they mention. So there are some questions where they mention that this is a rural hospital and a hospital with PCI facilities needs is like so many hours away, and it's going to take more than 4 to 6 hours to transfer the patient. So then you can say you will go for thrombolysis then and there before transferring. But if they say it's a rural hospital and there's a question that says you're able to airlift the patient within 45 minutes. So then in that question also you say you will airlift the patient to a hospital that has PCI facilities, right? So here the answer is PCI. So we go by exclusion, right? So it's a STEMI, you're not going to send the patient home, right? Thrombolysis, yes, it's an answer if the patient, if you don't have facilities for PCI and if you are unable to transfer on time, but there is no mention of such thing in this question, right? And then admit and wait for the troponin results. So generally in an MI, we will be doing it in our notes. So troponin becomes positive, as we know, in 6 hours. So if you're going to wait for the results, it's going to be too late. And then perform stress tests. So obviously in a patient with an ECG like this, having a STEMI, we're not going to go for a stress test. So that's one good thing in AMC is even if you are not sure of the answer, you can go through an exclusion sort of exclusion technique as well to get to your answer. So there'll be certain questions that you probably haven't read before, or it's something new or something. So you can slowly exclude the answers through this method, right? So that is one way of answering the AMC questions, right? So here it's obviously coronary angiogram and PCI. So this is a little bit, I added some slides from our lectures, also the theory classes, how we are going to go about. So we've taken it from the Australian Resuscitation Council, right? And how they come to the conclusion of acute STEMI, how they look at it in the ECG. So of course you have to have symptoms and brought on by exercise and not relieved by rest, right? So we need to change. So that is not relieved by rest when it's a STEMI. And you can get an ST segment elevation which is more than 1 millimeter in 2 successive leads, right? What do you mean by contiguous leads is not the leads in the picture that are next to each other. What they're saying is anterior, like AVL, 1 and AVL is anterior, 2, 3 AVF is inferior. So that is the contiguous leads, right? and newly developed left bundle branch block. So again, if it's an LBB, you're always managing it as an MI, right? Uh, so yeah, so we'll go through this in detail, of course, when we're doing cardiology. So unprovoked sustained chest pain with 12 lead ECG that might be normal with ST depression or TV infection. So it's not always an ST elevation MI, right? So it can be a non-STEMI. So again, if there is chest pain suggestive of an MI and the ECG showing depression, ST depression or T wave inversions also, according to the Australian Resuscitation Council, you take this as acute STEMI, right? And the management is the same then. So, ECG is first line. So we'll be mentioning those first line investigations, best investigation, all of that, because those are common ways of asking questions in AMCs. They will ask uh, what is the first line, what is the best investigation. So the first line is not always the best is not always first line. So you need to keep that in mind when you're answering the questions. Always read that last line. What they're asking? Are they asking you the best step in your management, or are they asking the next best step in management? So best step would be what you would do immediately, or best step is what is best for the patient in that particular condition. So always remember, in AMC they keep changing that. Sometimes you might have read this question in your past paper when you're doing revision, but when you come to the exam, they might put that same question, but they will change that last line. Are they asking the first line investigation? Are they asking the best investigation? They might just change that last line, and that will change your entire answer. So even if the question looks familiar, just skim through it, read through it as fast as possible, and see what they are asking for. Is it the same thing that you studied when you revised, or is it a different thing, right? So they tend to twist the questions. So yeah, so these are a bit from the notes and how you go through. So this is what I was saying, lead 2-3 AVF. So they are not going to ask you questions like this. Is 2-3A right coronary? They are not going to ask you that, but you need to know so that you know that, okay, this patient needs PCI, right? Because the right coronary artery is affected, right? And you should know which leads to look at also, right? So like this table is important because now for this question also, troponin takes at least 6 hours to show a change, right? So that's why we excluded that answer there, right? This is a bit on the management, so we'll go through all of that. I don't want to go through like an entire lecture today, and because I just want you all to see how this is done, right? So these are the therapies, uh, rescue angioplasty, how you do it, right? And STEMI within 12 hours of symptom onset in absence of comorbidities, uh, PCI or fibrinolytic therapy is recommended. So again, PCI or fibrinolytic therapy depends on the circumstance or the situation, right? So if they say cardiac catheterization, again, they mean this PCI with angioplasty, right, together. But it's all the same thing. So just remember there's thrombolytic or fibrinolytic therapy, there is uh, and PCI, right? So we just look at another question, again, cardiology related. 34-year-old male presents with shortness of breath and fever. After clinical evaluation and investigations, he is diagnosed with acute pericarditis. What are the expected ECG changes in this condition? So, again, if we go through our notes, then we are able to answer not only this, we can answer multiple questions that come around pericarditis. So, uh, in the theory lectures, we'll be going with one question, but then we will do the entire note on pericarditis, which is related to AMC only, right? So obviously, when you take pericarditis, there's so many things that you can study around it, but we'll be going through the high yield points that are necessary for your AMC, right? So like if you take pericarditis, this pleuritic chest pain is important in AMC. That is one thing they talk about in their questions, right? And the more than the friction rub, they are more interested in the ECG changes and how it comes, and we go through with that, right? Uh, so they are pleuritic chest pain. When they mention, just have your differentials in mind. These are the things that you can get pleural. So there are four P's, right? So we'll go through all of that: pneumonia, pericarditis, all of this causing pleuritic chest pain, pleural effusion, right? So uh, yeah, so that's the physical sign, right? Pericarditis preceded by viral respiratory or GI symptoms such as viral etiology, right? So if they give the question saying that the patient had a past recent history of some respiratory or GI illness, again, it could be a pericarditis secondary to a viral infection, right? And these are the common organisms just to keep in mind. And uh, so if they're giving signs of, say, they are saying pleuritic chest pain, as well as you can hear a friction rub on the left lower sternal border. And then they tell you the patient had a recent history of uh, a GI infection or a respiratory infection. So then you need to think about pericarditis. So uh, that's how they try to trick you. So you will be thinking, oh, this could be something related to the respiratory, right? It could be even it could be a pneumonia, but they'll give you other points. So you must think, okay, if there's a friction rub, pleuritic chest pain, one thing, it could be some pneumonia thing, or it could be a pericarditis. So then with the rest of the question, you try to exclude, right? Then, so we will, I'll just show you the guidelines. So, yeah, we'll go through the ECG also. So this is from the one thing you need to know is the how you treat the pericarditis. This has also been in previous questions. NSAIDs, colchicine. So these have been MCQ questions on what is the treatment, right? So some questions they say NSAIDs, the answer is NSAIDs only, colchicine only, or NSAIDs and colchicine. So you can use both actually, right? So this is all from the RACGP guidelines, right? Uh, High dose corticosteroids over 2 to 4 weeks is considered if it's secondary to any connective tissue diseases or like autoimmune diseases, right? So this is again given the link to the guidelines for pericarditis, and these tables are taken straight from the guidelines, and we'll just have a look at it when we're doing pericarditis, right? Uh, in AMC MCQs, one thing for pericarditis, they always mention this tachypnea and tachycardia. So just remember when they give you a pulse rate of 100, 110, they are kind of trying to tell you, okay, there is a tachycardia, right? They don't mention tachycardia in any of their questions. They always give you the pulse rate and you have to decide, right? And then tachypnea, right? Or decreased breath sound. So these are like important things that come in the question in AMC, right? So we'll go through the ECG changes. Yeah. So within the first 2 weeks, you have these changes there before they reverse. It lasts for almost 2 weeks, right? So one thing is ST elevations in all leads and PQ depressions, ST elevations and PQ depressions, all leads except AVR and V1. So we need to remember that. And the fact that these uh, ST elevations are concave, right? So they are smiling ones. So smiling elevations and PQ depressions except in AVR and V1. What happens in AVR and V1 is it's the other way around to this, right? So it's the opposite, right? So just see how that goes. So this is the ST elevation and it's concave. It's a smiling one. It's not like the STEMI ST elevation. And what they mean by PQ depression is it goes at least 1 to 2 millimeters below the baseline, right? This PR interval drops below the baseline. So this happens, um, it's called diffuse ST elevations because it happens in almost all the leads except for these two. In these two leads, it's the mirror image, right? The mirror image. Then we have something called spodic sign. So actually spodic sign, they don't mention it much in any of these texts, but if they give you an ECG and ask you to diagnose, if you're unsure what this is, you can always look for this spodic sign. And if that is present, then you can be sure, okay, this is an acute pericarditis, right? So what is spodic sign is basically this. So uh, from T to the next P. So this is the T wave to the next P wave. This line is slanting downwards, right? It has a downward slant, this line. So this is known as the spodic sign. So normal ECG, it would be straight, or even if you take a STEMI ECG, it would be straight, right? But in pericarditis, you have this downward slanting. So always look for this, right? That will help you to kind of differentiate it between a STEMI or a pericarditis. And another thing is the fact that in STEMI, you're going to look at certain leads together, but in pericarditis, it's diffuse, right? It's there in almost all the leads, right? So this is again a similar picture. So we'll be showing you a lot of the diagrams and stuff so that you can remember better than actually going through notes, right? So even these tables, I'll be putting it on the slides, but we'll be going through only the stuff that are really important and that have been asked in the exam, right? In the questions. And you can get the guidelines from us also, the links later, right? So this is again another cardiology related question. This is about abdominal aortic aneurysm. So there have been a few questions on that, right? So again, it's about a workup plan. So 65-year-old man presents with a history of 2 episodes of abdominal pain. After his workup, so there's an abdominal aortic aneurysm, right? So which of the following is the recommended management? So can you see in this question, they're talking about a lot of unnecessary stuff as well, right? Say gallstones in the gallbladder as well, right? So uh, AMC questions are not this short, right? So it's quite long. Their questions are quite long, and there'll be some unnecessary information also inside. But at that point, you will not be sure if this is needed or not. So you need to learn to read fast and skim through the questions, and how to, you know, sort of cut off those unnecessary bits of information, because if you go to read everything word by word, that's also going to take you time because those questions are long. Sometimes it takes you more than half a minute to finish reading the question, right? So in questions like this, if you just read the last part, which one of the following is recommended management for this asymptomatic AAA, right? So then you don't really need most of this, right? You just need the size of the aneurysm, and you need to know that they are asking you the recommended management, right? So when you keep doing questions, you will sort of master the art of trying to skip the unnecessary pieces of information, right? They give you a lot of investigation reports and vital uh, findings and all of that stuff. Sometimes it's not even needed, right? So this is from the RICGP guidelines again. This is what they are following, right? So you might think it's like too much. They're asking like, in terms of centimeters, what to do and stuff, but it's actually there. So uh, we just need to know how to find it. So that's what we will be helping you all to do to get to the right guidelines. Because sometimes when you go online also, you might find 3, 4 different case reports, guidelines, all of that for each topic. But there'll be one guideline which, they'll be following for your questions. So we will be guiding you through to get into those guidelines as well, giving you the links at the end of the lecture. And then here you just look at this. Uh, so the way I would remember it is like it keeps doubling here, right? 3, 6, 12, and 24. These are your intervals. From 3 to 24, you just keep doubling it. And you can, when you get a question, just work out the table on the side. On the side, you write these 4 numbers, right? Start from 24, half of 24, 12, half is 6, half is 3. And then on this side, what you can do is, this is more than 5 anyway, right? So how do you remember the rest? You put 3 here, right? 4, right? So here it's 3 to almost 4. And here 4 to 4.5, 4.6 to 5. So what I would do is, I'll write 3, 4, and skip this and write 5 here. And then work it out, right? So if this is 4, this is 3 to 3.9, right? And if this is 5 and this is 4, obviously here there's a 4 to 4.5, 4.6 to 5. So you don't have to remember these mini numbers, just know that there's a breakdown here with half a centimeter, and here the breakdown is 1 centimeter. So you write down 3, 4, and 5, and then write your table on the side. You'll be given a pen and paper to, jot down stuff and all that. So then you can guess, okay, what is the, so here's 3.8 centimeters, and they want your surveillance to be done every 24 months, right? So this is basically an ultrasonography that they want to do every 24 months. So how do you know it's an ultrasonography? It's actually there in the guideline. I just stole this table. We'll be giving you the links and you can go through the guidelines. They will like give you the details of it. So basically you just need to know this table, right, for your surveillance. And it's good to know these tables pretty well also, because you get a question like this, it's the answer is sure, right? You're sure to score that full mark for this answer, right? So this is again from the guidelines. What they say is ultrasound is the most accurate and best investigation. So that's another thing you need to know. AMC questions, they base it on what is the best investigation, what is the most accurate investigation. So it's good to know this point, that for abdominal aortic aneurysms, ultrasound is the most accurate and best. This comes from their guideline, right? It's for both diagnosis, all three: diagnosis, screening, and surveillance, right? So, what they say, it has almost 100% sensitivity and specificity. And when do you go for CT? CT is performed if they are planning to go for a surgery, right? So after you made the diagnosis, if you think it's too large and you need to go for a surgery, then uh, you go for a CT scan, right? That is to identify the exact locations and the soft tissue involvements and all of that, right? So in the same way, there are certain other surgical procedures also where they will ask you, would you go for ultrasound scan? Like in DVTs, would you go for ultrasound scan? Would you go for CT angiography? So again, if surgery is planned, it's CT. If it's just for diagnosis and screening or surveillance, that is follow up, then it's ultrasound scan. So when we're doing those questions also, we will relate it to this so that it's easy for you to remember both in this and this. This is the management, right? So this is about paracetamol poisoning. Uh, Again, here we have David has 40 tablets of paracetamol, that is 500 milligram tablets of paracetamol presented 1 hour ago, right? Which one of the following is the most appropriate management? So which one do you choose from here? So again, it's back to their guidelines. So they have a very detailed guideline on how you can manage the paracetamol poisoning, right? So I just took their tables. So this is again their guideline, their updated guidelines. There's a newer one on paracetamol poisoning. So they've updated it on the timings and what investigations you do and when do you discharge, right? So we have the links as well. So if you know this table, this is the updated one. If you know this table, you can answer any paracetamol poisoning case, right? So study this table. If it's less than 2 hours, the patient has presented, you can go straight for activated charcoal, right? And then you can do all the investigations. If it's between 2 to 8 hours, then you first go for the investigations. That is the serum paracetamol levels and ALT, right? So, and then you have to plot it on the nomogram. And if it's on over the treatment line, so then what do you do? If it's above the nomogram, what do you do? So they're asking if it's double the nomogram line, you need to go for NAC infusion. If it's not so, you can just go for the standard infusion. So they have like two different kinds. 1 second. So this is their update. So this yellow box is their update. So now what they say, what we used to know is if it's above the nomogram line, you go for the standard acetal and standard NAC infusion, right? But if it's double the line, double the concentration, right? Then that is if it's quite high, right? Then you have to complete acetal system infusion with double dose second bag, right? So this is their new update, right? And then if it's more than 8 to 24 hours, what do you do? If it's more than 24 hours, what do? You straight away start in acetals, yeah, the NAC infusion, right? And then how do you send them home, right? If the ALT is less than 50 or more than 50, what is the level of paracetamol concentration for each one, right? And whether you need further treatment or whether you need to continue the NAC. So we will go through all of those properly with the questions, right? So here we have a question on diabetes, right? So again, this is also a common question where they give you like values on like fasting blood sugars or postprandial blood sugars or HbA1cs, and then they ask you what is your next step in management. So again, they have its guidelines. So actually, if you know those tables and their guidelines, uh, any question related to this, you can answer. Whatever, if they change these values, if they give you an HbA1c instead of an FBS, what do you do? All of that. So when you're, that's why we said when you're going through a question, just read around the guideline, because the next question on diabetes will be obviously something different, right? So if you read around the guideline, these are very easy questions to answer because it's very straightforward, right? So here we have a 50-year-old male patient comes in for an annual checkup. He's asymptomatic and his family history has a family history of type 2 diabetes. His fasting blood sugar is 5.8 millimoles per liter, right? So what is the next best step to, so now these are unnecessary information they have given us, right? So you're considering the next best step to assess his glycemic status, right? So here is they're asking the next step. So which one do you do? Do you repeat it in 3 months? Do you go for an OGTT? So over here, we don't really do OGTTs in non-pregnant patients, but over there, they consider OGTT as well, right? Uh, so this is the table for you to go through for diabetes according to the Australian guidelines. If you know this table, you can answer any DM question without confusion. So this is their RSAGP guideline, the link, right? So I won't be going to it now and showing you because it's going to take time, but you all can always type 2 diabetes RSAGP guidelines and you will get it. But the gist of that guideline is this table. You just have to know this table, right? Just read through the guideline once so you get an idea of how their management goes, and then have this what you can do is all these tables like this snack table, those are really important. You can straightforward answer the questions if you know this table, right? So all this what we give you, you can actually create a folder on your phone, right, with pictures. That's what I did. I created a folder for ECGs, a folder for x-rays, and a folder for these tables, so that in the last minute or like every day in the evenings, we should just go through these tables so that it sticks with you. And these are the things that you actually need to go through one day before the exam, right? So it's hard to kind of remember it for a long time. So you have these folders on your phone so that even when you're like, lying down, you can just go through those tables, right? So we'll be giving you these tables particularly. Uh, so asymptomatic patient assessed if they are like high risk. So you test the blood glucose or you can do an HbA1c. So they will give you a question. They will either give you the patient's fasting blood glucose level, or they will give you the patient's HbA1c level. So you need to be able to interpret both. So if it's less than 6, they are unlikely to have diabetes, but since they have a high risk, you need to retest in 3 years. So these are MCQ questions, right? What do you do next? What's your next best step? So retest in 3 years. 6 to 6.4, you retest in 1 year. And more than 6.5, you need to repeat the HbA1c. So that is something we don't really do here, right? So this is the Australian guidelines. More than 6.5, you repeat the HbA1c, right? You don't go with a fasting sugar. You don't look at the HbA1c and say, okay, we need to do a fasting blood sugar and ppbs. You have to go for a repeat HbA1c here. So if they have come with a blood glucose level, your fasting blood glucose, if it's less than 5.5, again, it's similar to less than 6% HbA1c. So you need to retrace it in 3 years, right? And 5.5 to 6.9, you go here for an OGT. So this also has been a question. What do you do next? It's an OGTT, right? So if the patient comes with a fasting blood glucose between these two, you're going for OGTT, right? Again, not something we really do here, right? If it's more than 7, then you have to repeat the fasting blood glucose, right? Again, similar to this, right? So when you get the OGTT reports, depending on your 2 hour, basically you don't look at this row here, it doesn't matter. OGTT, the 2 hour, less than 7.8, that is, if it's normal, then you need to retest in 3 years. Then impaired glucose tolerance, you need to retest it in 1 year, right? And then if it's more than 11, it's definite diabetes, right? So this is the diabetes line is quite different to what we do here. So we need to keep this in mind. Other thing is, if you know this, you're sure to get the answer right. So it's not about like, uh, doing that exclusion thing in the questions, right? So here he has a HbA1c of, fasting blood sugar of 5.8. So it's here. So you have to go for an OGTT, right? So here we have, this is again a question on gout and pseudo gout, right? So this has been a question I actually came in my exam as well. It was something that was circulating pretty often in the exam. So it's a 64-year-old man who has hypertension and type 2 diabetes, presents to the ED with hot, swollen, erythematous right knee, which he says is too painful to bend. He takes several medications, and so he has thiazide diuretics here and ramipril, right? And his right knee is swollen, erythematous, and he has psoriasis affecting the scalp and the elbows. So there's a lot of information here, and they are trying to get you to something, right? Both CRP and creatinine are raised. So they're giving you this x-ray of the knee joint and they're asking you, obviously they didn't put this arrow here, they just gave us this exact x-ray is what we got, right? And they asked to come to a diagnosis, right? So is it gout or pseudo gout, right? So how do you differentiate between the two, right? Obviously it doesn't sound like an osteoarthritis, but you might, because he has a history of psoriasis, you might think it's a psoriatic arthritis. If it's septic arthritis, he's going to have high fever, right? And so how do you exclude all this? So we'll be in the proper rheumatology classes, we'll be doing how to differentiate between gout and pseudo gout, how to differentiate between osteoarthritis and rheumatoid arthritis. So there are some mnemonics which you can use to just remember it. So obviously in osteoarthritis, you will get more, those osteophytes and loss of joint space and all of that, right? So there's a mnemonic called less and loss, how you differentiate between rheumatoid and osteo, then gout and pseudo gout. So this one, so if you just look at the guidelines, this is again from the RSCGP guidelines for pseudo gout, right? So pseudo gout is also another known as calcium pyrophosphate crystal disease, caused by calcium crystals, right? So they have also given a similar picture to this, right? When these crystals occur in joints, they can create intense pain, redness, warmth, and swelling in a joint. So all the pseudo-gout questions will come with this picture, right? And the knee is the most commonly affected, right? So, but it also occurs in large joints such as hip, ankle, wrist, elbows, and shoulder. Uh, Gout and pseudogout have similar symptoms, but the causes and treatments are different. So this is directly from the RSCGP guideline. This part is also important where knee is commonly affected, but other joints can also be affected as the first joint or the only joint to be affected. Because there have been questions in the past where they have given the picture of pseudogout, but said it's the right great toe that was affected, right? So then you're not sure whether it's gout or pseudo gout because it's the right grade toe, because that is the normal place where you get gout rather than pseudo gout, but actually the answer was pseudo gout. So how do you come to that diagnosis? So we will go through the guidelines for gout, pseudo gout, and all, and see the differences, right? So they try to trick you. They put like the great toe is affected, but they're giving you the pseudo gout picture, right? So this is again from RSCGP guidelines. So they are giving you some causes of gout, right? So family history, obesity, then high blood pressure, glucose intolerance. So this patient has diabetes, right? Renal disease, taking diuretics. So he's on uh, thiazide diuretic, right? and he has high blood pressure, and he has also diabetes. So he has some of the predisposing factors. So it's all there in the guidelines, whatever they put in the question, right? So what causes pseudogout? Uh, what causes pseudogout is previous trauma, family history, excess iron, and metabolic. So look at this question, what they have done. This is actually, the answer is pseudogout here, but they have given you the risk factors for gout. So this is how they try to confuse us, right? They're given the risk factors for gout, but your answer is pseudogout here, right? So here, these are the risk factors they gave us, right? So how do you come to the conclusion? So I will even share the picture again. So what they said is calcium crystals, they deposit in the space between the joint, right? And it's is seen as a whitish sort of a fluffy exudate. That's what they call it, like a fluffy exudate. This is also there in the RxCGP guideline if you go through it. And pseudogout, they will have nodules, right? And soft tissue or swelling as well. So we will go through some pseudogout x-rays as well when we are doing the proper rheumatology class. So it's this this is the part in the X-ray that is going to lead you to the answer of pseudogout. This fluffy exudate in the middle. This part you don't get in gout, right? So we'll share the link. I haven't shared the link here on this. I'll give you the link to the guidelines as well. So then this is another question where they try to sort of twist it to look like an MI sometimes. So 53-year man presents with intense pain over the past 4 months. Problem started with the eruption of a rash over the area. The rash resolved in 2 weeks, but the pain has persisted with an increased intensity. And he describes the pain as constant, sharp, unbearable, affecting his lifestyle, and he has used PCM ibuprofen. Uh, and then they're given his past history as well, right? And this is the only place that he has pain. So, what do you think it most probably is? So this sounds like a herpetic neuralgia, right? So this is again there's a neuropathic pain guideline. So uh, that's one thing. Like now, since you have the links, it's easy for you to go through the guidelines, because when you try to type RACGP and post-herpetic neuralgia and stuff, it's really difficult to find the guidelines. So they have it under something called neuropathic pain update, right? So since we are given you all the guidelines here, you all won't take time looking for the guidelines, or can go through it. This has been taken directly from them, and I have just highlighted in red the stuff that are needed for these MCQs, right? So if the pain lasts for more than 3 months after the onset of herpes, then it's called postherpetic neuralgia. Management options include uh, prevention with vaccination, early antiviral treatment, and the pain management, right? So the pain management here is in post-herpetic neuralgia, is gabapentin, TCA, opioids, and capsaicin cream or lignocaine patches, right? So this is the management for post-herpetic neuralgia. There is pain that is lasting for more than 3 months, right? Sorry. So there's a similar thing when you get this on the trigeminal nerve, you can end up with trigeminal neuralgia, right? This is a very like, it gives sort of a shooting pain. It's an excruciating pain, and it comes on those branches of this fifth cranial nerve. So there are 5 branches. So there are 3 branches. It can come on one of those branches, right? So if they give you a picture, so there have been questions on both, right? So if they're giving you post-herpetic neuralgia in a picture of trigeminal neuralgia, that means it's affecting the trigeminal nerve distribution that is on the face, then your first line management is carbamazepine, right? So remember that if it's on the trigeminal nerve distribution, your first line management is carbamazepine. So they will give you on your answers, they will give you gabapentin and all this other stuff, but your choice should be carbamazepine. But if the neuralgia is elsewhere, other than the trigeminal nerve, then you go for these gabapentin, tricyclic antidepressants, whatever they would give you one thing, right? So that is the catch there, right? So this patient has it on the chest wall. So they sometimes give it like a chest pain, and they give you a picture like it sounds like an MI, but at the end you realize it's a hepatic neuralgia, right? So for this patient, we will go for gabapentin because they have. So there's pregabalin, gabapentin, but the guideline mentions uh, gabapentin, right? So this is again from the guidelines. So management is divided into prevention and management of the acute infection as well, right? And then the treatment of post-herpetic neuralgia. So there are three parts: prevention, acute herpes zoster infection management, and post-herpetic neuralgia. So as we know, post-herpetic neuralgia or herpes zoster comes from the dormant viruses in the dorsal root ganglia. That is the dormant varicella virus. So when you're infected with varicella, that is chicken pox, even though the infection disappears, this virus remains dormant in your dorsal root ganglion. And when your immunity drops for any reason, this virus travels along the nerves there. That's why it's always along the nerves. When it comes back along the nerves, then it's known as herpes zoster. And then it gives this acute herpes zoster infection, right? So one way of prevention is the pediatric varicella uh, vaccination, right? Or in adults, you can prevent it by there's something called the Zostavax. So that is patients have to pay one when they mention in the RSG guidelines, not in the this PBS scheme means that the patient has to pay. So that is another thing that you need to. You don't really have to worry about it, but just know there's a vaccination for adults separately, right? Uh, Early antiviral therapy. So if they give you a patient who has come with an acute infection, what do we need to do? Again, go for early antiviral therapy. And other thing is you need to give corticosteroids and oxycodone for the acute pain. So uh, if it's an acute infection, make sure you don't tick off gabapentin, pregabalin, TCA, all of that, right? So if it's a acute infection, your pain reduction is by corticosteroids and oxycodone. But post-herpetic neuralgia, that is, they have given us the definition, more than 3 months of pain after the onset, then you go for these the previous management we discussed, right? So there are three things to remember in post-herpetic neuralgia in herpes zoster. One is uh, the management of the trigeminal neuralgia. When it's affecting the trigeminal nerve, it's carbamazepine. When it's anywhere else in the body, it's these drugs, right? And if it's acute infection, the pain management is corticosteroids and oxycodone. That for the pain management, right? So these have all been MCQs. So this is again from the RSCGP guidelines. So here they have put it in a table form. Trigeminal means you go mainly for carbamazepine. Post-hepatic, you can go for these drugs, right? And if it's diabetic polyneuropathy, they have another set of drugs that you can give, right? So this is first line. So always remember the first line, because the question is always next best, or what is the first line investigation, right? So this is the they have a table on the dosages and side effects and stuff like that. Just good to read. So then again, a dermatologic question about acne and how you manage acne, right? So which treatment do you choose for an acne that looks like this, right? It's a severe acne, right? With so this is again from their guidelines. How do you manage the mild acne? How do you diagnose it? How do you diagnose moderate acne? What are there pustules? And then moderate to severe and severe acne, right? So nodules, cysts, which are painful, face, neck, upper trunk, this is known as severe acne, right? And then I've just highlighted in red the main things that we need to know in management of acne, right? So this is from the guidelines. It's the table looks very busy, but I just box the stuff that you need for the exam, right? So if it's there's one called first line therapy, and then there's the maintenance therapy, right? So in case of mild acne, just remember topical retinoids, right? If it's uh, moderate acne, you can go for uh, topical antibiotics, right? Or topical retinoids, both. And the antibiotic they use is doxycycline, right? Moderate to severe is again the same thing. So I didn't box it. And severe acne is something they question us. You have to go for oral isotretinoin as your first line. So you think that oral isotretinoin should be something that you give later when it's not responsive, but no. They go straight off for isotretinoin as first line in case of severe acne. So and then for female patients, you can also add hormonal therapies, right? And then again, isotretinoin is some points you need to know about isotretinoin is you need to think of whether the patient is pregnant or not, then they can't take it. If they're planning pregnancy, they can't take it. And when you do give isotretinoin, again, an advice you have to give is to defer pregnancy for 3 months after stopping the isotretinoin, right? So all of these things are like included in the guidelines, right? So this is again like we'll go through this when we're doing the proper class. So again, these are some MCQ questions, right? So this is the RSCGP, the attachment that we got it from. Topical antibiotics are effective with topical clindamycin, erythromycin having similar efficacy, right? And then if you go for oral, um, is given only for moderate to severe and severe. So like you see in this table, for mild acne, they don't really go for oral antibiotics. They prefer starting it at this level, right? So doxycycline is the agent of first choice, right? So if they asked you the next best or the first line is doxycycline. So this has been a question, right? Minocycline is limited by poorer tolerability. So people are less tolerable, so they go with toxin first line. And then remember the contraindication in children and pregnancy. And then this is also an MCQ question. Due to photosensitivity reactions, patients taking tetracycline should be counseled on sun exposure. So in Australia, they're very concerned about this sun exposure thing because they have very high rates of skin cancer, right? Melanomas. These are very like I think the highest in the world is there in Australia. So they're very concerned about the photosensitivity. So this has been some MCQ questions about counseling the patient on using sunscreen and avoiding too much of sun exposure, especially if they are on doxycycline, right? So like in our theory classes, we'll be doing it like this. And then those questions that I'm talking about will be put on, the exact questions we'll be putting it on in the question and answer class, right? So you can actually read up through these guidelines and come so that when we are doing the discussions, you can discuss, right? So then this is again a common question in rheumatology. They ask about polymyositis, statin-induced myositis, and all of that. So we need to know how to differentiate between this. So what I did was I put everything into a table. So if you can take a picture of this and uh, add it to your folder uh, where you have, those tables and stuff. If you know this picture, you can answer any question related to this that comes with the background of investigations, right? So if they're giving you a set of investigations and then they are saying to come to your diagnosis here, if you know this table, you can answer any of those questions, right? So this table again has been taken from the guidelines because remember there are like so many uh, circulating notes, and even I think on Americ some things have been wrong in related to this CK being elevated or normal. So I actually went to the guidelines and found out how uh, these different conditions display the CK levels, right? So go with this table. So we have Ruth, 70 years of age, presented with a complaint of muscle weakness for the past couple of weeks. She has hypertension, coronary heart disease, and she's on ramipril and atorvastatin. So here is how they, put everything together, and you sort of get confused. So she's on ramipril. So could it be a statin-induced myositis, right? Sorry, she's on atorvastatin. So could it be a statin-induced myositis, right? Physical examination is remarkable for bilateral shoulder girdle muscle weakness and tenderness. You ordered blood tests and are significant for elevated ESR and creatinine kinase. So, which is the most likely diagnosis? So, is it uh, polymyositis? Is it statin-induced myositis? Right. So, you can exclude dermatomyositis because if it's dermatomyositis, they need to give you this similar picture with some skin lesions as well. So, they didn't give you that. Could it be polymyalgia rheumatica? Polymyalgia rheumatica, again, you get bilateral shoulder girdle muscle pain and weakness, and bilateral hip girdle muscle pain and weakness, uh, either both or one of the two. So you get that in polymyalgia rheumatica as well. So see how they have confused us. So now we don't know which one it is. Can it be adhesive capsulitis? So how we differentiate it between all is by the investigation. So normal CK and elevated ESR, right? So here is the normal CK and here is the elevated ESR. So you can go with polymyalgia rheumatica, right? But if they have said elevated CK, then it can't be PMR, right? So if it's elevated CK, elevated ESR, then we need to think of one of these, right? So this is again straight from the guidelines. They've given everything very clearly on how you come to the diagnosis of polymyalgia rheumatica, uh, and how polymyalgia rheumatica is associated with giant cell arteritis. And then how do you diagnose giant cell arteritis, right? Uh, as in, what are the criteria that will warrant you to give some urgent treatment? So, giant cell arteritis also has been a very common question. Uh, Again, in AMC, they're very fond of associations. This disease is associated with something else. So it comes even in pediatrics, psychiatry, all these associations. So if you want, you can also start like making a list of associations. So what they do sometimes in the questions is we will go through in rheumatology. Because polymyalgia rheumatica is associated with giant cell arteritis, they will give you a question where the patient has come to you with polymyalgia rheumatica. All the symptoms of polymyalgia rheumatica. and all these findings, right? But they will also give you some thing on the side saying temporal artery tenderness or new onset headache or something like that. And then they will ask, what is it? So it's probably a GCA on the background of polymyalgia rheumatica, right? So the answer is not polymyalgia rheumatica. She's a known patient, but the acute problem now is having a GCA, right? So this is the guidelines for diagnosis of yeah. So this is very important. All their PMR questions will have a patient who is more than 50 years of age. They give that definitely if they're talking about PMR and bilateral shoulder pain, right? So new hip involvement, right? So you can get hip involvement, you can get shoulder pain as well, right? Then morning stiffness is more than 45 minutes. So this more than 2 weeks thing has been removed now, right? So they are going with these guidelines, the 2012 one. Elevated CRP and ESR. So that is for polymyalgia rheumatica. You get all three elevated. Remember on the table, we had all three elevated. So absence of peripheral synovitis or positive rheumatoid arthritis serology is also part of the picture now. And then they have added a new thing, that is your ultrasound findings as well into the classification, right? Or the criteria, right? And then how do you diagnose giant cell arthritis? So these two are connected. All the questions that come, generally they connect this PMR and giant cell arthritis together. If they are more than 50 years. So obviously if PMR is associated with giant cell arthritis, both have to be more than 50 years, right? New onset headache, temporal artery tenderness, right, or decreased pulse, uh, and then ESR more than 50, right, and positive temporal artery biopsy. So these are diagnostic criteria. But then there'll be other features as well, like jaw claudication and all of that. So we'll go through all of that because some questions will give you those features as well, right? And then how do you treat, right? So how do you treat giant cell arthritis versus how do you treat PMR? So this is why they give you both the scenarios in the question. So you make the right diagnosis and then you can't choose the right treatment, right? So they might give you both these treatments and then see whether you have made the right diagnosis. So giant cell arthritis is an acute emergency. So if they give you any feature suggestive of any of these, headache, temporal artery tenderness, these are more than 50, all of that, then you need to think about GCA and you need to treat it urgently to prevent blindness, right? So giant cell arthritis can cause permanent blindness. So before that happens, we need to go for this. So when you read the question, you need to be able to decide whether this is GCA or PMR. So this is the treatment for PMR. This is the treatment, a high dose for GCA. So you just need to remember that you need to give a high dose, 40 to 60 weeks over 4 weeks, and 40 to 60 milligrams over 4 weeks, and here 15 milligrams over 3 weeks, right? And then this part is not necessary for you to like remember per se, but just read it and know that it's being tailed off over so many months, right? So the next 3 weeks, this is your dose. The next 4 to 6 weeks, this is your dose. So you don't need to really know all of that. Just know the initial one. So that is what is mostly questioned, right? So then this is something we need to know. In all the questions where corticosteroids is an answer, this has also been sort of a question that comes on the side. Especially in rheumatology where most of the treatments require corticosteroids. This is from their guidelines again. How do you, like, when do you assess bone mineral density when giving corticosteroids? So this has been a question, right? So when you're steroid treatment is going to last more than 3 months, like in this case, right? Here you're giving for 4 weeks, then another 2 weeks, another 2 to 4 weeks, then 2 months. So you're exceeding 3 months of steroid treatment. Then what do you do? Do you uh, continue the treatment, or do you first check for bone redundancy? So according to their guidelines, you have to, if the treatment is going more than 3 months, you need to check the T-score, right? And also start on proper calcium supplementation with vitamin D3, right? And if the T-score is less than minus 1.5, then you need to consider alendronate, right? So then, yeah, this comes under our rheumatology lecture, right? How you manage the PMR. So there's headache, jaw claudication, tongue claudication, right? Uh, so again, this is straight from the guidelines. GCA should be considered as a differential. It occurs in 16 to 21% of PMR. So uh, how and when do you do the temporal artery biopsy? Can you give the steroids before temporal artery biopsy or not? That is again, a question where they'll give you a scenario and they'll ask you whether you're going to do temporal artery biopsy and then give the steroids, or would you give the steroids first? So here they say it's all the answers are there in the guidelines. So temporal artery biopsy should not delay the prompt institution of high dose corticosteroids. So this has been a question, right? So this is your link to the guidelines, right? So we'll just do a few more questions up to like 8 o'clock, and so you can just get an idea on like everything, how we'll be going around the theory classes and the question classes, right? So theory classes will be adding a question and then talking about everything around it, and then the remaining questions around that same topic will be discussed on the question class, right? So here we have a question on uh, sort of like berylliosis, byssinosis, how you diagnose uh, these conditions. So each one, uh, how do you differentiate between these things? Berylliosis, byssinosis versus silicosis. What are the differentiating points? How do you know that, okay, this woman is exposed, or she worked in a cotton mill, and then she comes with when the work week began, she started to have tightness in her chest. So when she goes home for the weekend, she's fine. But when the work week begins, she starts this SOB. So which one is it, right? So how do you come to the diagnosis? So we'll be like differentiating all of that and like giving you the points to remember for each one, right? So if it's byssinosis, it'll have similar symptoms to asthma, right? You need a chest X-ray because here again the patient will uh, complain of what do you call this, Monday disease, right? So it's called Monday disease because through the disease, patient complains the symptoms get worse when they come to work on Monday and gets better when they're off work. So this is one feature of byssinosis, right? So this is the same picture they have given here, right? So how do you diagnose between obstructive and restrictive lung diseases, right? Uh, so that is from the FEV1. So we will be doing teaching you how to calculate FEV1 below 80% is obstructive. How do you find restrictive lung disease from the FEV1, right? Uh, so we'll be explaining to you. So obstructive lung disease is basically uh, the bronchi going to spasm. So when you're exhaling, forced expiratory volume will always be less than 80% because you cannot expire fully because the lung is going into spasm, right? and it should be calculated against there's a formula. So we will go through all of that so that you don't have to memorize which one is obstructive, which one is restrictive, right? And then there's asbestosis. How do you differentiate asbestosis from byssinosis, right? So you will get this pleural membrane plaques. So we'll show you pictures and stuff. Asbestosis, the X-ray will have a typical plaque sort of patches on the chest X-ray, right? So asbestosis always can lead to bronchogenic CA or mesothelioma. So these two uh, are connected. Again, associations of asbestosis. So remember that in the questions, right? And sometimes the people, they'll give a question where the patient worked so many years ago in an asbestos uh, environment, right? And now coming with this. So just because they haven't been exposed to the last 5 to 10 years doesn't mean that it can't be a bronchogenic CO mesothelioma, right? Then silicosis, right? How we can diagnose it on the X-ray. Berylliosis is again similar to sarcoidosis, right? How it occurs. And then yeah, so there are lots of, we'll be going through each one of these in the respiratory lectures, and how you can differentiate, and also what it means, right? Each one, what is the specific exposure that leads to it, right? So these are few links from the guidelines that we went through for that, right? Uh, yeah, so this is like about what do you do in the emergency setting? Do you do spirometry, or do you go for peak expiratory flow? So it's all in their asthma guidelines, how you come to a diagnosis. So there's a new asthma guideline. These are the links. I've given you the newer links. 2024, where they have updated as well certain management. So when you're going through Amadex, especially when you're reading through asthma, there are certain answers that are old now. We'll guide you through with that. They have changed the guidelines, and certain drugs they prefer not giving anymore. So these are not answers anymore. So these answers are there on certain older question banks. Don't follow those, right? So when you're going through asthma, especially in so this chromones, indochromyl sodium and sodium chromoglycate have been discontinued and are no longer considered therapeutic options, right? So this is from their most recent guideline, right? So handbook's recommendation that sodium chromoglycate can be considered for children who are unable to tolerate Montelukast, or where an NSA treatment option is preferred, has been removed, right? So this is straight from their guideline. So in children, we don't give chromoglycate anymore, right? And it's not considered as a therapeutic option, right? So minor amendments include the roles of spirometry in clinical practice, salbutamol dose monitoring, and reinforcement of key messages for written asthma action plans. This is from their guideline. Uh, when you do spirometry, so that's what this question is, an older question. So here, depending on that new guideline, the answer may change, right? So we need to read up through the guidelines and come to our answer. So again, here, this is 6-year-old child having wheezing, right? And you give inhaled fluticasone and salbutamol, which is most effective in preventing further episodes. So sodium chromoglycate, remember, is no longer, right? So he's already on fluticasone and short-acting, right? That is salbutamol. So these two also you can exclude in your answers. When you're giving a short acting, you don't give a long acting as well. So your answer is coming to Montelukast. So you can go with exclusion as well. So this is the asthma handbook. It's quite long. You need to, we'll show you how you can skim through it and there are certain boxes that you need to read. If you read those boxes, it's enough for you, right? So this is again another important topic. We have sort of made it easy to understand how to come to the diagnosis uh, uh, about patients coming with uh, DVT or thrombophilias, right? Pulmonary embolism, when you're suspecting pulmonary embolism, right? So how do you come to this answer, right? So most of the time we tend to get these answers wrong. But if you go through their guidelines, they have given you a clear workup on how you can come to this answer. Which investigation are you going to do for this patient? So here we have 26-year-old lady comes to the emergency department with pleuritic chest pain and SOB, and she's suspected of having a pulmonary embolism. So they've already given you in the question that they are suspecting a PE, right? Uh, so we don't need to go through that. There's a table where you can sort of uh, one of their flow charts where you go through and find out whether you are suspecting or not. So you can cut off that table now because they've already said you're suspecting, right? She has a family history also of thrombophilia. And which of the following is the investigation of choice for her? So now, how are you going to choose a 26-year-old lady having a family history of thrombophilia or suspecting PE? Are you going to do a duplex? Are you going to go for VQ, CTP, D-dimer? So which one are you going to choose? So it seems very confusing, but if you go through their guidelines and those flowcharts that they have asked you to follow, the answer is very easy, right? So I have sort of taken from their guidelines uh, whatever we need to know to answer all these AMC related AMC MCQ questions uh, in terms of investigations for PE, right? So here's the symptoms. So always remember, in all the AMC questions related to PE, they have given us a tachycardia. Sometimes they just mention pulse rate is 100. Then you need to know it's a tachycardia, right? Pleuritic chest pain, they always give you pleuritic chest pain, right? And sudden onset dyspnea. So dyspnea is sudden, right? Uh, they don't always give you this fever, hypoxia, hemoptysis, cough, and all of that. But these three I've noticed are consistently they are in the questions, right? So remember these symptoms. Then predisposing factors. So sometimes they might give us a predisposing factor, right? Most of the time it's a post-op patient they talk about, right? And then ABG findings. So certain questions they have given these ABG findings as well, right? So this is again from the guidelines. This is how you come to your um, conclusion. So Wells score is uh, it determines the probability of pulmonary embolism. So basically in this question, what they're saying is they already applied the Wells score and they are thinking she has pulmonary embolism, right? So some questions they wouldn't have applied the Wells score, but they are give you all these features. So you need to apply the Wells score, and then they will ask you what is the investigation, right? So they won't ask you is this pulmonary embolism or not. They will expect you to do that, and then come to their question will be on the management, right? So when you're applying the Wells score, there's a table. So we will slowly go through that. Now is not the time to like go through all this to be too much for you. So once you apply the Wells score, you will come to a score, right? There's a simplified one and a normal one. So less than 4 or less than 1 or high risk, right? So if it's high risk, this is from RSAGP. If it's high risk, you have to go for imaging. So what is the imaging you're going to decide on? So if it's high risk, you don't have to worry about your answer. It's definitely you're going for an imaging. So to decide on what imaging, again, there's another flow chart to follow, right? If it's low risk only, you have a problem. Are you going for imaging or not in this low risk patient? So then they have something called this perk rule, right? So we will go through all of that. And if it's negative, then you have excluded pulmonary embolism. So you don't need to do any imaging. But if it's positive, you need to do a D-dimer. So when do you do a D-dimer? In case of low risk patients, and this PERC rule is positive, then only you go for D-dimer. So if D-dimer is positive only, we go for imaging, right? So they have a nice flow in things. So you don't have to like worry about how am I going to answer this question, because it's all there in the flow charts, right? So this is your well score. We'll go through it in detail. I actually remembered only this simplified well score because scoring is very easy. Everything gets a score of 1. So, and if it's 1 or, yeah, obviously if the simplified well score is 1, then it comes on to the low risk. If it's more than 1, it comes on to high risk, right? So you can decide whether you want to use the well score, simplified well score, but I find simplified well score is easy because the scoring is also easy to remember, right? Everything is 1. So these are the points. So heart rate more than 100, immobilization 3 days, previous DVT, hemoptysis, malignancy. So all of these things, if they give you, and if you have scored for any of these, that means it's more than 1, right? More than 1 means it has to be 2 and above, right? If it's 2 and above, then you need to go for imaging, right? If it's 1, then you need to go for this PERC criteria. It's a rule out criteria. So you will have to just sit down and read these criteria properly to sort of understand it, what they're trying to say here. So if it's yes, if these are all yes, 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 you're answering to these questions, then you don't need further investigation. That means it's very, very low risk. But if any of these questions you are answering no, that means if they're asking if pulse is less than 100 beats per minute, no, that means it's tachycardia, more than 100, then you need to go for D-dimer, right? So these tables again should come into your that folder, right? So you're constantly going through this, and then you know, okay, well score, this is how I calculate, this is how you go for the per criteria, right? So then how do you choose your preferred method for definitive diagnosis, right? So generally, uh, it's CTPA. So your definitive diagnosis is CTPA, but there are some exceptions. So there are questions also they have asked based on this. Uh, you don't go for CTPA when the female is less than 55 years, right? Because of the risk of exposure to radiation and the breast cancer risk, right? Then less than 40 GFR, right? So they might give you a CKD patient. I mean, they have given questions in the past. There are some past questions where they have given you the EGFR of the patient. So then your choice is not CTPA, your choice is VQ scan, right? If they have any allergy or if they are pregnant, you cannot go for CTPA. So if you are suspecting pulmonary embolism, your definitive diagnosis, your preferred investigation is CTPA, except in these 4 conditions, right? Then you need to know whether they have a normal chest X-ray or they're hemodynamically stable. In addition to these 4 conditions, so if they're having any of these 4 conditions, along with an abnormal chest X-ray, then you need to still go for CTPA. So even if it's a CKD patient, if the chest X-ray is not normal, there's no point in going for VQ scan because it won't show anything. Then we need to go for CTPA. If it's a, say, pregnant patient, but with pulmonary embolism suspected and hemodynamically unstable, then CTPA, right? So even though there are 4 exceptions, you still have to see, is the chest X-ray normal? Is the patient hemodynamically stable? If it's normal and stable, then you can go for VQ scan because VQ scan takes time, right? And it gives a wrong imaging if the chest X-ray is abnormal, right? So that's why. So they might give you these conditions, but they might mention hemodynamically unstable. Then it's CTPA. So remember this slide. So if you can remember this, then it's easy for you to come to your uh, investigation, right? So a little bit about how we will go about this. So again, how do you differentiate between ADHD, autism, and Asperger's? So they will give you questions, but you will not know which one. So how do you differentiate? So Asperger's people are mostly uh, like they are verbal, they can speak out well, right? But in classic autism, they have uh, like problem with the nonverbal communication, right? So here, no language deficit and nonverbal communication is less severe. So they are just on the high IQ range people. So if you think of Einstein, they say he had Asperger's, right? And then ADHD, uh, they again, how do you identify ADHD? So there's a lot in the guidelines, so we will go through those in like with pictures and stuff. What are the points for ADHD, right? And then what are the points for autism? So autism again, early onset versus Asperger's is late onset. Autism IQ is low, Asperger's IQ will be on the high side, right? And here, verbal and non-verbal problems. Autism is verbal and non-verbal problems, right? It's not there in this, right? So, uh, yeah, so this is again a bit too much to do now. So how some questions they have tried to confuse us by adding constipation, encopresis, and autism, all of that together. So then you don't know whether the answer is encopresis or whether the answer is developmental regression, right? So how do you identify? So autism is related to constipation. These are two associations. And then what is encopresis? Encopresis is soiling or soiling with stool in children, right? It normally occurs in children. So it can be due to either constipation or it can be due to a developmental regression. So we need to remember that. So then how they try to, uh, there are some questions where they have tried to confuse and you're confused about what the answer may be. So here, that's how we will sort of derive the answer through going through these guidelines, right? So then you don't have to have any confusion regarding that, right? So this is again a constipation encompasses question where child is soiling her underwear. So is it some questions they give similar questions where they give the answers regression or constipation. So you need to be able to choose whether she's having a developmental regression going on, whether she's having a constipation. And then again here it could be oppositional deviation, defiant disorder or regression because she's having quarrels and she's fighting and stuff. So some people may think it's ODD. So we need to be able to differentiate between those as well. So we'll be teaching you as with each lecture, pediatrics, psychiatry, all of this, and we'll be showing you the different questions uh, that have come up and how they try to also make it a bit confusing. So you will remember how to sort it out when you're doing the exam as well, right? So you'll know that, okay, this is not this is what they're talking about, even though they have made it look like one thing, right? So in the upcoming lectures, we'll be taking topic wise and sort of spelling it out for you all how to come to the diagnosis, how to go through, which guidelines to go through, right? And we will also compare similar questions so that this is the range of questions that can be asked in this topic. And if there are any other questions that have come in from other topics, like say when you're doing pediatrics, there might be associated psychiatric questions. So we will compare it and show you all, how they have incorporated some psychiatry part into pediatrics, or how they've incorporated some rheumatology part into something, some cardiovascular thing. So all of that we will show how it's how you derive the answer, right? And then we'll also show you like how if you don't know the answer at the exam, how you go by that exclusion method, right? To come to the answer, and it really helps, right? So that's about it for today. It's just an idea on how our lectures will go. So do you all have any questions for now? Anything y'all want to clarify, please ask so we can. Otherwise, obviously, you all will be added to a WhatsApp group. Y'all can put your questions out there, right? So even after the lecture, if y'all are having any doubts, y'all can put it out on that WhatsApp group. And again, during our lecture, if you all find anything contradictory, y'all think it's not this, it has to be that, you can always share your doubts and your concerns, and even in the WhatsApp group. And if we are also unsure of something, then if there's a confusion, we will always go through the guidelines for you all and share it with the guideline on the WhatsApp group. So then you are sure of the answers, right? Um, so if there's any questions, feel free to ask us anytime, right? With that, I'll be wrapping up this session, and we meet you all with the next session. They will inform you all of the date and time of the next session, most probably Tuesday or Wednesday, right? Okay, thank you.